Respected senior members amongst august audience, dear friends and colleagues, greetings of the day. The most important step of PCNL is making a short, straight access track through a FORNIX into the pelvic calyceal system. Let us discuss today the three techniques of making PCNL access. Our index case is a patient with a stone in the renal pelvis, and because 80% of us do prone PCNL, our patient is also lying prone position. Now let us start understanding the PCNL access. Now if this is our supine patient, please pay attention to the axis of the kidneys, and when the same patient is turned prone, you can very well see that the axis of the kidney is 30° tilted towards the coronal plane. So this is the tilt of the kidney which we are seeing when the patient is lying prone in front of us, and these are our targets. These are our targets where we have to make a puncture. This is the posterior calyx, this is the anterior calyx, through which we have to enter the pelvic calyceal system to remove this renal pelvic stone. Once you have identified your target, you should see the target straight on its face, and therefore you should position the C-arm with 30° tilt towards you. It means the image intensifier should hit your head and the X-ray tube should move away from you, so that your genitals are also protected, your fertility is maintained. When you make a puncture in this direction with the C-arm tilted 30° towards you, you are likely to make an entry through the convex border of the kidney, while if you make the C-arm in 0° and try to make a puncture, you are likely to make puncture through this portion of the renal parenchyma. And this much migration of your renal access of 1 to 2 centimeter from medial to lateral aspect is going to reduce the amount of bleeding which is going to take place. Because we know when the renal artery enters into the pelvis, into the kidney, it divides into an anterior branch and posterior branch. These branches go on dividing further. They fan out on the anterior and posterior surface of the renal pelvis, and then they go into branching, and ultimately at this level, say about 1 to 2 centimeter medial to the convex border, they make an arc which is called arcuate arteries. From arcuate arteries there are vessels which are originating vertically like this, going up to the renal cortex, up to the convex border. So if you make a puncture in this direction, you are likely to not injure the renal larger vessels, while if you make a puncture in the middle of the renal parenchyma in this area, you are likely to injure the arcuate arteries and create more damage. Therefore, you should try to make your puncture through the BRODELS white line, through the convex border of the kidney, not through the middle of the renal parenchyma. So you have positioned the C-arm in this way with the 30° tilt. Now what do you see with C-arm? One exposure of C-arm is like seeing the world only with one eye. One eye is not sufficient. It is like taking a picture with a camera, and camera doesn't show everything. Camera only gives you, or one eye gives you, or one view of the C-arm gives you only the length and breadth. It does not give you exact depth perception. What I am saying is clear by this picture taken with the camera. If you are standing here and taking this picture, this moon appears to be in the cart. You cannot experience the distance between the moon and the cart. If you have to identify this distance, if you have to see the third dimension, you will have to move 5 feet on this side or to the other side to see the distance between these two. And therefore, we are seeing every object with two eyes, and then we are able to see the three-dimensional view. So once you have a C-arm intensifier positioned like this, C-arm image like this, whatever needle tip comes onto this needle, whatever needle tip comes onto this line will be shown as if it has reached at the target. Your needle may be at the skin surface, your needle may be exactly at the target, or your needle may be much deeper to the target, but all these three needles will be seen in this view as if you have reached at the target. Now to see the distance, since we don't have two C-arms, now we will have to shift this one eye or one C-arm to the like a second eye. We will have to shift it from 30 degree to 0 degree. And now once you shift from 30 to 0 degree, whatever needle tip comes on this line will be seen as if it has reached to the target. And this is the needle which will be seen on the target whether the C-arm is in 30 degree or the C-arm is at 0 degree, and if this needle is seen at the target in both, then we are at the target. But once you tilt from 30 to 0 degree, I will repeat, you shift from 30 to 0 degree and your needle tip which was seen at the target in 30 degree, if this needle tip moves lateral to the target, you are superficial. And vice versa. If your needle tip which was seen at the target in 30 degree, but once you have moved your C-arm from 30 to 0 and it moves medial to the target in the next image, then this is a deep needle, has gone too deep. You will have to come out and make a superficial puncture. This is the crux of PCNL access. Now what are the techniques to enter into the pelvic calyceal system? There are three techniques which are popular: bullseye technique, triangulation technique and gradual descent technique, which we will discuss one by one. In bullseye technique, you can position the C-arm at 0 degree. This will be the target which will be seen. You can make a needle puncture from here, go vertically down, keeping the needle tip and needle hub in the same straight line, go deep, 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 deep. You may be superficial, you may be at the target, you may even cross the target, but your needle will be seen at the target continuously. So this is bullseye 0 degree puncture. When you position the C-arm at 30 degree, now you are not making an entry from here, you are making an entry from here, but keeping your needle tip, needle hub in the same straight line, superimposed over each other. You are not seeing the full length of the needle, and the needle is going deep, 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 deep. You will certainly at one particular time, you will hit the bullseye, you will reach at the target. So whether you are having a bullseye 0 degree, bullseye 30 degree or any degree, and if you are able to maintain the needle tip, needle hub, everything in the same straight line as is seen in this particular video, then you are maintaining your needle in the same straight line, and at one particular moment you will definitely hit the target, you will reach into this pelvic calyceal system. This is called bullseye technique. But as you saw, the hands are getting exposed because your hands are coming on the way in the same X-ray beam image. So bullseye technique, the track which we make, if this C-arm is at 0 degree and you make a track like this, you are entering, or your one particular segment of your track from skin up to the calyx is vertical, is at 90 degree. Now you have to go a little more deep to reach up to this renal, to the pelvic stone. So you will have to turn your amplard sheath and the nephroscope towards this in line with this infundibulum to reach up to this. And when you turn like this, you will create some fulcrum effect and injury at the renal parenchyma level. As you see, this is your track at 0 degree which you have made, and now once you are turning your amplard sheath to come in alignment and take entry into the renal pelvis, you may tear the renal parenchyma and there will be some bleeding. Not only that, when you are making a puncture like this, you can imagine the kidney lying down like this, and you are making a puncture in this area, you are likely to hit the arcuate vessels in depth, and you are very close proximity to the big vessels, and there are going to be more chances of bleeding. So bullseye technique is a easy technique. It's a sure shot technique. Only thing, you have to maintain your needle tip, needle hub, everything in the same straight line. Go deep, deep, deep. You will certainly reach up to the target. These are medial punctures far away from the colon, so colonic injuries are less common. When you make the posterior calyceal, okay, that your guide wire will go in easily, but if you puncture the anterior calyx in this bullseye 0 degree, then your guide wire may hit the opposite wall. Only hydrophilic terumo guide wire may find its path, otherwise it will be difficult, and guide wire placement will be very difficult in these cases. So the disadvantages of bullseye puncture are, these are medial punctures at a distance from Brodels line, so more chances of bleeding and surgeon's hands are getting exposed. Guide wire placement may be difficult. Maybe renal parenchyma will get torn when you tilt the amplard sheath, and when you are going with a angled track, it is a not straight access. If you are going with the angled track, your entry and mobility within the pelvic calyceal system will be restricted. Coming to the triangulation technique, this is nothing but a calculated bullseye technique. In this, you position the Siam at 0 degree and mark the target on the skin as A. Now tilt your Siam to 30 degree and mark the target at B. Now you have this distance you can measure A and B. In this bargain, when you are doing this marking, you have actually created a right angled triangle on the skin surface, on the patient's body. If you see it with the trigonometry, you have created a 90 degree angle over here, and when you have shifted the Siam from 0 to 30 degree, the angle created at angle C is 30 degree. Obviously this angle will become 60 degree. So you have created a right angle triangle, 90, 30, 60 angle, and you know one arm of this triangle which is in front of you, which you know the distance between A and B. So now it is very easy to calculate with the Pythagoras theorem the length of AC and length of BC. These two arms can very well be calculated, and as these calculations of Pythagoras triangle, they tell us in a 90, 30, 60 degree angle, arm AC means the distance of the target from the skin at the 0 degree, if you start, will be 1.73 times the distance between A and B, because this arm is 1.73 times the arm AB. While if you start your needle puncture at 30 degree mark from point B and go in a bullseye fashion straight up to the point C, this distance will be twice the distance of AB. So if your distance between A and B was 3 centimeter, now you have started your puncture at point B and you puncture up to 6 centimeter depth, you will reach at the target. So this triangulation technique is bullseye technique where you exactly know at what depth you will hit the target. Coming to the third technique, this is the triangulation technique where you mark a point A, mark point B, measure the distance between these two, and then you can start at point A. If you measure AB 1.73 times AB, you will reach the target. If you try to come from this angle, it will be twice the length of AB and you will reach the target. This is triangulation technique. Lastly, let us discuss gradual descent technique. In this technique, the tilt of Siam is always 30 degrees. But we don't start the needle puncture at the target as you see on this skin. Don't start your needle puncture here. Place your needle 3 to 4 centimeter lateral like this. If it was a bullseye puncture, I would have placed the needle here. But once I have placed the needle tip on the skin 3 to 4 centimeter lateral, my needle will be seen like this. And from here, now I will be making a journey, gradually descending down up to this target calyx. Like a aeroplane lands onto the runway, I will be entering through the convex border of the kidney in alignment with the infundibulum, and I will be able to reach the renal pelvis easily for this renal pelvic stone in the same alignment. So gradual descent technique will take you, the advantages will be, you will be descending down through the through the concavity of the calyx. You will be entering through the convex border of the kidney from the Brodels white line, and the bleeding complications will be less. But these are the lateral punctures from the skin. They have easy guide wire placement because it is in the same alignment. There is minimal or no bleeding, so you are at peace, and there is a better stone clearance. It offers excellent mobility within pelvic calyceal system because you are in the same alignment. And there is only disadvantages, there is a learning curve, because if you start descending from here, and if you go this way or if you go this way, you will not hit the target. You have to know exact angle of entry so that you are reaching at the target. So there is a learning curve. It is not a sure shot technique. You have to learn this technique. And once you are so lateral, you are closer to the colon, which sometimes at the lateral border of the kidney. So the colonic injuries may happen, and you have to be extra careful. So we have three types of access into the pelvic calyceal system. This is 0 degree bullseye. You are entering through this portion of the renal parenchyma. This is 30 degree bullseye, a little more lateral. You are making an entry into the renal pelvis, and maybe you are in alignment with the infundibulum. And lastly, gradual descent technique. You are not coming from 0 degree bullseye, you are not coming from 30 degree bullseye, you are starting 3 to 4 centimeter lateral, and then entering the convex border of the kidney through the Brodels line and entering in alignment with the infundibulum, reaching it up to the renal pelvis. So these are the three ways to enter a calyx: bullseye 0 degree, bullseye 30 degree, and a gradual descent technique. Take home messages will be: pelvic calyceal access should be through convex border of the kidney. C-arm should initially be positioned with 30 degrees tilt. Don't depend only on monoplanar view of C-arm. It will not give you the depth perception. You have to be very accurate, scientifically correct. So you should watch the movement of your needle, and you should reach to the exact depth in the same angle. So you should see the target with the two planes. Gradual descent technique provides an ideal access. If you can learn this technique, you will be very comfortable. Thank you very much for your kind attention and listening to me so patiently. I take this opportunity to invite you on October 1st and 2nd, 2022 at New Delhi to participate in 9th International Live Operative Workshop. Our previous 8 workshops have been very successful in teaching and training the youngsters the technique, the basic and advanced techniques of making initial puncture and to be successful in PCNL. So you are invited to participate in PERCON 2022. This is the 9th International Live Operative Workshop. Thank you very much for listening to me. Thank you.